Welcome to the First Fill podcast, created by members for members. I'm Katie Meyer, VP of Education at APhA. I'm delighted to announce that we are relaunching the First Fill podcast as a members-only offering created by members. This series is designed to showcase the expertise, creativity, innovation, and real-world experiences of members of APHA's communities. Each episode is designed to spotlight APhA members with the goal of delivering timely, relevant education for our listeners. APhA members have the opportunity to serve as a guest to showcase their innovation, and only APhA members can earn CPE for listening. In this episode, we are featuring a member from our medication management community, Tonino Michienzi. Tony will discuss an innovative pilot that he was able to take part in supporting patients transitioning from the hospital directly into the community. Before we dive in, let me introduce our guest today. Tony, why don't you introduce yourself?
Thanks, Katie. Hi, my name is Tonino, or I go by Tony as well, Michienzi. Been a pharmacist for about 33 years and been with the Walgreen Company most of the time.
Thanks so much, Tony, for joining us today. So why don't we dive in and tell me a bit about how you got started with MTM and conducting CMRs with Walgreens.
So as I mentioned, I've been with Walgreens about 33 years, graduated in 92 from Fair State University in a little small school in Northern Michigan, Big Rapids, Michigan. Been in various roles with the company: pharmacist, pharmacy manager, pharmacy supervisor. And when I was a pharmacy manager at the last point, I had always been a preceptor with APhA students, fourth year students from the local schools in the area. And the school had changed the rotation from a 4-week block to a 6-week block. So I had to figure out what I was going to teach these kids for the next extra 2 weeks. And this was about 2004. MTM was just starting out. I wanted to get into it and learn more about it. So I decided I was going to learn about it and then teach the kids to do it. And to be honest, I really wasn't an expert at actually conducting the CMRs. I call them my kids, my students were really good at it. And I got put on a list, at least at Walgreens. I was the number 2 store in the company in terms of volume. The number 1 store was my colleague who works with me right now. He was actually doing it himself. So the kids made me look good. And I decided, wow, this is really good. The company noticed and they said, Tony, would you like to do this full time? And I said, well, I am working full time. They said, no, no, no. Would you like to do MTM full time? And I was like, cool. So pulled me out of the store and we started off by just physically going to 10 different stores on a 2-week rotation. And then we returned to those stores. But we quickly figured out that there were barriers with that, especially when we would call patients and they would call back, but I might be at another store the next day or 2 days later, and of course, they wouldn't know where I was at that time. So we figured out that we had to get to a local store or a local location that we could use. So we camped out at our local specialty location. We stayed there for about 2 years. Unfortunately, they got too busy, and we had more employees than they ended up having. We had interns. We had a great internship that was based on MTM. So I dropped the management APhA and made it an MTM APhA, which again at that time was kind of a new thing. And then we were able to take 3,000 square feet out of a store, and we now exclusively take this space and we have our own MTM hub, which is unique, at least at Walgreens. Nobody else has this kind of space in Grand Rapids or across the country, where we're using that to teach a DIPI class in MTM. We also have an APhA in MTM. I now have a residency with a rotation in MTM. We can't focus that residency only on MTM. And then I also have a LAPI, which is a longitudinal APhA, the first community longitudinal APhA at Fair State University in this, and I'm the director of that as well. So, and we've been able to do a lot of different projects with it. So that's kind of what got me going with it.
Yeah, that's awesome. Thanks so much for sharing. It sounds like you really accomplished a lot in the MTM space. So you mentioned barriers. So I want to dive into that a little bit more. So what are some of the barriers that you feel, based on your experience, that community pharmacists and their patients face during transitions of care specifically?
So I think a big problem is communication. Just any community pharmacist that's gone through the process of trying to get refill authorizations or trying to get a prior authorization know that physicians have a great way to electronically send us data, but we don't really have a good way of getting a hold of them. We can't just, it would be fantastic if we could just go through SureScripts and just respond back to a script saying, hey, your script says one tablet by mouth twice daily for 10 days, but you've given a prescription for 35 tablets or something like that, where there's some kind of discrepancy there. Or there's an allergy to penicillin and they've prescribed amoxicillin. Can we quickly discuss that? Can we just send a message back? And unfortunately, we don't have that way. So communication is one thing. Two, patients not getting their prescriptions on time after discharge, prescriptions going to the wrong pharmacy, pharmacists not having access to an EHR, which I think is brutally important that we have that in the future. Just having that EHR would be able to answer so many questions for our pharmacists. I think community pharmacists want to be more informed, would love to be able to have access to that information, would love to have access to lab values and vitals and what exactly the patient went into the hospital with, because it would be able to help them to complete the prescription order correctly, efficiently, and at the right price for the patient in a much better manner.
Absolutely. Thank you so much for that perspective. All right, let's shift gears a little bit. So, I understand through your work more recently, you were actually involved in kind of a special project related to transitions of care. Can you tell listeners about the project and some of the outcomes that you were able to achieve with it?
Right. So, a local hospital in the state of Michigan, a regional hospital, came to us because of our experience in MTM. I've now been doing this full time for about 10 years. Came to us and said, "Hey, we need some help with a project." It was sponsored by a payer, a major payer in the country. Said, "Hey, we will pay you to complete post-discharge CMRs for our patients because we want to try and decrease that readmission rate." For those of you out there that don't really understand what the readmission rate really means, the CMS identifies hospitals and grades them based on those readmission rates, and we want to decrease those readmission rates. We think that by completing a proper CMR for a patient, optimizing their medications, making sure they're taking those medications properly, make sure that they're on guideline medications, we can hopefully decrease that readmission rate. And the gold standard, generally speaking, is 30 days. So we want to try and minimize the readmission rate uh, 30 days for that same ICD-10 code, or if at all possible, for all cause readmissions. And that was our goal. We were specifically given a hospital that had the worst readmission rate out of their 9 regional hospitals that they had. So they chose the worst one, and they also chose patients who were highest at risk for being readmitted. Generally speaking, those 3 comorbidities were heart failure, COPD, and diabetes. So, and many times, of course, patients had all 3 of those at one time. So the process was that one of the transition to care nurses would contact the patient and would agree or would talk to the patient and say, we're going to have one of our pharmacists. And as far as the patient was concerned, we were a pharmacist from the hospital. It made things much simpler. We were not a Walgreens pharmacist. We were just a pharmacist from the hospital. 2 days after discharge, they would get a phone call from us, which would have meant a day after they were called by this particular transitions of care nurse. Initially, we were told just attempt 2 phone calls to the patient, and if they don't answer by then or don't agree to do it, move on to the next patient. Well, my colleague and I, after doing about 30 of these, figured out, no, we're not going to do that. We're going to make sure we talk to every single patient. So after we made that decision, we were 100% effective in being able to contact every patient. We weren't going to take no for an answer. So if it took 7 phone calls, we called them 7 times. So we completed every CMR after that point, and we found some problems. And we found out the prescriptions were not sent to the pharmacy that they were supposed to be sent to. We found problems with guidelines not being followed for heart failure, for pneumonia, patients who were in for pneumonia but hadn't received any pneumonia vaccines. So, of course, we used an immunization registry as well as the patient's EHR. So that was what was probably the most unique thing, is that outside of the hospital, we had access to the patient's inpatient EHR. We had access to all the information. We also had access to know where the prescriptions were going to outpatient wise, regardless of whether they were going to a Walgreens or not. In fact, most of the times they were not going to a Walgreens. So we were interacting with other pharmacies as well. And we talked to those pharmacies many times to check on those medications. So 2 days after, we would call the patient, talk to them, find out, did you pick up your medications? Are you taking these medications? Why aren't you're missing this vaccine? Whatever the case may be. Uh, so we did that for the first 100 or so, which took us about 6 months into the program. We were also allowed to message back through the EHR directly to the provider in the hospital and or the primary care physician on the outpatient side, or any specialist cardiologist, endocrinologist, et cetera, that they would be seeing post discharge, and talk to them about any gaps that we saw in guideline medications, or if the patient chose to not get a prescription. Mainly that would be because of prior authorizations, et cetera. So we felt that we were definitely at an advantage compared to a regular community pharmacist that wouldn't have had access to that EHR. We did that for 1 year, and then we said, okay, if they come back to us and say we're going to continue doing this in the future, we're going to do something else. So in what we are calling phase 2, we decided we're going to have a 2-day post-discharge CMR, and then we were also going to do a 14-day CMR and a 28-day CMR. And the reason for that was payments by CMS are based on that 15-day readmission and a 30-day readmission. So we're going to try and minimize those as much as possible. In the end, we were able to decrease the cost. We were not statistically significant on readmissions. As I said, these patients were the highest risk. They were at about 24% pre the admission, pre the pilot. They were 24% readmission. We got it down to about 19% readmission, but because we didn't have enough power in the study, we only had about 250 patients that we actually completed CMRs. We didn't have quite enough power, but we certainly saved them money, probably on the order of $2.2 to $2.3 million in readmission costs.
That's great. It sounds like such an interesting project. You certainly demonstrated resiliency for sure with contacting 100% of patients. And it seems like you were really practicing at the top of your license, which is great. Want to kind of dive back into those barriers that we discussed a little bit earlier.
Sure.
So just tell listeners a bit more about what you learned through this project, specifically regarding strategies to improve that communication between the community pharmacists and other healthcare providers at transitions of care specifically.
Well, if you put yourself in the eyes of that patient, where they're kind of blinded, like they don't know what's happening exactly with everything that's going on. We were given the exact same discharge paperwork as the patient. So that was really nice because we could follow along with the discharge paperwork, and we made sure that they were following along with us. And we would say, all right, it shows here that you were supposed to receive this, X medications, these 10 medications. Do you have them? Oh, I only got 4 of them. Okay, well, what's going on with the other 6? Let's find out. So because we knew where the prescriptions were supposed to be going, I knew where to call to be able to resolve those issues. So many times it was drug was out of stock, but it wasn't communicated to the patient. So maybe that was a temporary thing. The drug needed a prior authorization. So that might have been, let's think of an X blocker. So Eliquis was on the formulary, but the patient was given a different medication. So we would try and make that switch for them, call back to the doctor, make that switch. Or we would find out that the prescriptions didn't go to the pharmacy that they were supposed to be going to, and I'd actually have to make some phone calls to find out where those medications ended up. So we were in a very fortunate situation. It was a blast to do this. I had so much fun. Our residents use this as their poster project, and I'm actually doing a CE later on with APHA as well, at presenting that at APHA. A little more detail about this as well. So this is really identifies, the change of fee for service versus value-based care. So where we want to improve those outcomes as pharmacists, and having the most information possible will help us to be able to do that. And I think that's what demonstrated more than anything else.
Absolutely. Thank you, Tony, for such an insightful discussion about your thoughts, both related to your project and how we as community pharmacists can improve transitions of care. So, just to summarize the discussion for our listeners today, there are several barriers to effective care when patients are discharged from the hospital. Issues with prescriptions that occur, including requirements for prior authorization, high costs, lack of transportation and access, maybe incorrect prescriptions sent over to the pharmacy, and several others can lead to errors and potentially readmission. Community pharmacists are also at a disadvantage because they generally lack electronic healthcare record access and adequate discharge documentation to make those informed decisions on behalf of their patients. In this episode, Tony discussed a pilot program that he participated in where pharmacists called patients directly post discharge and conducted CMRs. They found that many patients were missing necessary vaccines based on comorbidities or could benefit from treatment optimization in a variety of disease states, such as diabetes, cardiovascular disease, and COPD. Within the hospital setting, as a result of Tony and his team's interventions, all-cause readmission rate trended down to roughly 19% during the program, and these were in the highest risk patients as risk stratified at the hospital. So, what should pharmacists consider? So, approaching transitions of care. So, if a patient comes to your counter and says, I just got discharged from the hospital, put yourself in the patient's shoes to help them navigate these barriers that they're likely going to see. So, as an example, collect information, right? Make sure that you have their allergies documented. Get a list of comorbidities from the patient. So that way you have pertinent information, why they were in the hospital, and you can have those more thoughtful conversations and really use your clinical skill set to help the patient ensure that they have what they need following hospital discharge. And that's all the time we have for today. If you didn't catch episode 1, we featured APhA member Marissa Cavaretto, who discussed her perspectives on assisting patients on the other side of the coin, the inpatient TOC pharmacist perspective. As a reminder, CPE for the First Fill podcast is available for APhA members for free. So don't forget to visit the Learning Library at learn.pharmacist.com to earn CE credit for this month's podcast. If you're interested in becoming a member and taking advantage of the additional free CE that we have available exclusively for members, visit pharmacist.com. Take care, and thanks for listening.